Welcome to Rehabilitation Sciences YouTube channel. We are here with an interesting topic on sacroiliac joint dysfunction. And we have with us Professor Dr. Deepak Raghav. He will be talking today on sacroiliac joint dysfunction. Dr. Deepak, we would like to have your consent for making your lecture live on YouTube, sir.
Yes, sir. No problem, sir.
Thank you. Thank you so much for giving your consent. And moderator today, Dr. Sagun Agarwal, we have with us, and he will formally introduce our faculty today and start the session. So, Dr. Sagun, we invite you to kindly proceed with the session.
Thank you, sir. Good evening, everybody. For today's lecture, Sacroiliac Joint Dysfunction, we are having with us Dr. Deepak Kumar. Dr. Deepak has did his bachelor's in physiotherapy from DAV Institute, Yamunanagar, and master's in physiotherapy from IMR Institute. Currently, he is pursuing his PhD. He is professor and principal in Santosh College of Physiotherapy. He is having more than 15 years of the teaching and clinical experience. Sir has gone a lot of certification in manual therapy, kinesiotaping, dry needling, and sir is has been keynote lecture, has taken a lot of keynote lecture in national and international conferences. We welcome you, Dr. Deepak, on Rehabilitation Science Group. Thank you for your time and for your lecture. Thank you.
Thank you, sir. Can I start, sir?
Yes, sir. Now you can start, sir.
Good evening, everyone. Today, our topic is sacroiliac joint dysfunction. Sacroiliac joint dysfunction, what is the problem within the sacroiliac joint which leads to low back ache and so many problems. So, we start with sacroiliac joint dysfunction. Our sacroiliac joint is made up of one sacrum bone and two ilium bone, that is hip bone. So, we discuss with brief anatomy of the sacroiliac joint. It is a plain synovial joint, that is modified epiarthrodial joint. It is a stable joint, rigid joint, and relatively immobile. That means it is very little movement is available in this joint, allowing effective load transfer. Each of two SI joints, there are two SI joints, are about 1 to 2 mm wide. That is, the joint is 1 to 2 mm in width. So, the sacroiliac joint can considered as a two joint. Why it is two joint? Because the sacrum is situated between the two ilium or two hip bone, that is iliosacral joint and sacroiliac joint. Why? The term iliosacral means that innominate moving on the sacrum. Innominate means that is a part of the hip bone, that is ilium is moving on sacrum, that is sacrum is fixed and ilium is moving. So, that why it is iliosacral joint, and the sacroiliac is sacrum is moving within the innominate, that is two hip bone, that two hip bones are fixed and sacrum is moving within the two ilium bones. So, there are two ligaments, mainly the primary ligaments and secondary ligaments of SI joint. So, first we discuss the primary ligaments. There are three primary ligaments. First is anterior sacroiliac ligament, which is on the anterior side. That means if the face side is anterior side and back side is posterior side. So, anterior side, that is anterior sacroiliac ligament, and posterior side is posterior sacroiliac ligament between sacrum and ilium bone. Interosseous ligament is beneath the posterior sacroiliac ligament, that you looked in the picture, that second picture, interosseous sacroiliac ligament, and over that the posterior sacroiliac ligament is present. Then secondary ligaments are, there are two main secondary ligaments, sacrotuberous ligament and sacrospinous ligament. This is the thick ligament which start from ilium bone and insert in the ischial tuberosity. This is a long, broad and longitudinal or vertical ligament, and beneath that if we cut the sacrotuberous ligament, then we find the broad horizontal ligament which is sacrospinous ligament. Then come to the pubic symphysis. There in on pubic symphysis, that the hip bone, that the pelvis makes the ring with posterior side sacrum with to iliac bone, that is to hip bone, and from the anterior side the ring is closed by pubic symphysis. In the pubic symphysis, it's a cartilaginous joint which joins the two ends of the pubic bones. The pubic symphysis associated or concise or fixed with in his place by the help of three ligaments which are superior pubic ligament. You can see in the picture in the right side, upper side superior pubic ligament is there, inferior side inferior pubic ligament is there, and posterior side posterior ligament is present. Then before the SI joint dysfunction or SI joint pathology or any problem in the SI joint, we consider the one term, that is sacralization. You may be heard of that. That sacralization means the sacrum bone, that is which is made up of 5 sacral vertebrae which is fused together, and the fifth lumbar vertebra which is mobile on the base of the sacrum, but in sacralization that fifth lumbar vertebra is fused with the sacrum. It may be unilateral or it may be bilateral. In unilateral sacralization, one side of the transverse process of the L5 vertebra is fused with the sacrum, and in bilateral sacralization, fifth lumbar vertebra is fused with the both side with the sacrum. Then come to the lumbarization. In lumbarization, the S1 vertebra is mobile and it is not fused with the sacrum. So in lumbarization, the lumbar vertebra becomes 6 lumbar vertebra. That S1 is converted into L6, and the fifth 5 sacrum vertebra is now converted into 4 sacrum vertebra, because really S1 is mobile and it becomes L6. So this is lumbarization. This lumbarization and sacralization is very important in the treatment part when you are giving mobilization or manipulation for SI joint or lumbar joint for any pain, whether it is low back ache or it is SI joint dysfunction. If you don't know that it is lumbarized or sacralized, then you will harm the patient, and if you mobilize or manipulate, then it will create more pain rather to it reduce the pain. So it is very important point from the student point of view. First, diagnose whether the patient is not with lumbarization or sacralization. Then come to the function of the SI joint. What is the main function? It connects spine to the pelvis, absorb vertical force from the spine and transmitting them to the pelvis and lower extremities. That means the whole body weight is come from head, thorax, hands, it goes to the pelvis through the lumbar vertebra, and from sacrum to the hip and then to the femur, and from femur to the pelvis. So it is transmitting the force, load transmission. Then come to the axis of the SI joint. How SI joint work or how SI joint is moving. SI joint is a very simple joint or SI joint is a very complex joint. When you understand, it is a very simple joint. Why it is complex? We can say they have multiple axes in the SI joint. So first is superior transverse axis. There are 3 transverse axes in the SI joint. First is on S1 level, that is superior transverse axis. Second on S2 level, that is middle transverse axis. And third one is inferior transverse axis, which is on at the level of S3 sacrum vertebra. Then come to the next, that is left oblique axis. When we look the sacrum from the posterior side, that means face anterior and back is posterior. So when we looking the patient from the posterior side, the right side axis that is right oblique axis, that green one. You can see in the picture that green one is the right oblique axis and red one is the left oblique axis. Oblique means that we cut that obliquely. So right oblique axis, left oblique axis, and then vertical axis between the two half, that right and left, between that line is black line is vertical axis. So 1, 2, 3, 4, 5, 6. There are 6 axes in the SI joint. So movement in 6 direction occur in the SI joint. So first movement, or you can say movements of the SI joint, the first movement is physiological movement. Physiological movement means the voluntary movement, like in shoulder complex or shoulder joint, we can say flexion, extension, medial rotation, lateral rotation. All these movements are physiological movements which are voluntary movements. So first is physiological movement of SI joint is bilateral anterior sacral nutation. That means sacrum is going in anterior direction, the base of the sacrum is going anteriorly and apex of the sacrum is going posteriorly. That is bilateral anterior sacral nutation. So in that the pelvic is going posteriorly. So if bilateral anterior sacral nutation is there, then there is a posterior pelvic tilt. And second movement is bilateral posterior sacral nutation. That is base of the sacrum is going posteriorly and the apex of the sacrum is going anteriorly. That is bilateral posterior sacral nutation, in which pelvis is going anterior. That is anterior pelvic tilt is present in the bilateral sacral posterior nutation. Then come to the next movement is, next physiological movement is left sacral torsion on the left oblique axis, and fourth is right sacral torsion on the right oblique axis. Left sacral torsion means on the left oblique axis. You can take one matchstick. Suppose this is a matchstick or any rectangular small block. If you place this block, that this is the right side, this is the left side. If you place this block on the left hand like this, then this axis is oblique axis, left oblique. This is left oblique axis. I am putting this block in the left hand. This is left oblique axis. And torsion means movement. So if I push this block from posterior direction, this is torsion. So left oblique axis and left sacral torsion. This is the left oblique axis. Then right sacral torsion on the right oblique axis. If I put this block in the right hand, then it is right oblique axis. And if I push on the left side of in this way, then the movement is right sacral torsion on the right oblique axis. This is the normal physiological movement of the SI joint. Then come to the next physiological movement, anterior sacral nutation with exhalation, and sixth is posterior sacral nutation with inhalation. That means when we inhale, when we exhale, there is anterior sacral nutation. The sacrum is going in the anterior direction, and in inhalation, sacrum is going in the posterior direction. These all the movements are physiological movements, right? And next is the non-physiological movements. The non-physiological movements are those movements which are not in our control, that is non-voluntary movement. So there are some non-physiological movements. Left sacral torsion on right oblique axis, that I explained just before. The oblique axis is right oblique axis from when we are looking from the posterior side. Right side obliquely is the right oblique axis and left side is the left oblique axis. So first is left late sacral torsion on the right oblique axis, right sacral torsion on the left oblique axis, left unilateral anterior nutation, right unilateral anterior nutation, left unilateral posterior nutation and right unilateral posterior nutation. I will explain these movements in next slides. So, come to the muscle that reinforce and stabilize the SI joint. The SI joint is controlled or stabilized and reinforced by a certain group of muscles. When there is imbalance in these muscle group, then SI joint dysfunction occur due to muscle imbalance. So, these muscle groups should be in well controlled manner and in strengthened position. When there is shortening of one muscle group or lengthening of one muscle group or weakness of one muscle group, then the dysfunction occurs. So the muscles which stabilize the SI joints are first erector spine, lumbar multifidi, abdominal muscle, that is external and internal obliques, rectus abdominis, transverse abdominis, in hamstrings such as bicep femoris. So these all muscles are very important muscle in SI joint stabilization. When you rehabilitate the SI joint pain patient, or you rehabilitate the back pain, you must focus on these muscle groups. Without the strengthening and balancing of these muscle groups, the pain never go. So these muscle groups are very important. So you should look after these muscles. So what is the causes of sacroiliac dysfunction? The causes of sacroiliac dysfunctions are: first is very common traumatic, second is mechanical. In mechanical, they are hypomobile or hypermobile joint. Hypomobile means that is the joint is subluxated, and hypermobile is microtraumatic, and third is systemic condition. I emphasize one thing in this hypomobile, that is subluxated. The subluxation, that is the different thing. In hypomobility, the joint is subluxated in other manner. That is not it's a real subluxation. It's a minute, very minute subluxation which are not visible in the X-ray. If you expert in the special test, then you realize or diagnose this hypomobility, and then you find that this subluxation. So don't confuse the term with subluxations. Then the systemic cause of the sacroiliac dysfunction. So there are some systemic causes which cause the SI joint dysfunction. These are: first is inflammatory condition like ankylosing spondylitis, rheumatoid arthritis, and joint infection like brucellosis, tuberculosis, metabolic disorders, gout, hyperparathyroidism, miscellaneous osteosis condensus, and Paget disease and sacroiliac dysfunction. These are the systemic causes. Now, how we diagnose or how we can find out, and what is the idea about what are the clinical signs of the sacroiliac joint dysfunction? Because in back pain also the painful area is the same, and in other hip pathology the painful area is the same. So these are the some clinical signs which can when we check this and we find and diagnose, that is the SI joint dysfunction. So first is stiffness and pain with walking. When a patient walk, there is stiffness and pain. Second is pain opposite side with walking. Third is pain same side with walking, unilateral pain below L5, and pain with sit to stand. Not stand to sit, it is sit to stand. उठने जब पेशेंट को खड़ा होने में प्रॉब्लम होगा तो वो SI joint involvement हो सकता है, right? Then coccydynia and groin pain. These are the clinical sign of the SI joint dysfunction. Now come to the sacroiliac somatodysfunction. Forward, first is forward sacral torsion. The second is backward sacral torsion, bilateral sacral anterior nutation, bilateral sacral posterior nutation, unilateral sacral anterior nutation, and unilateral sacral posterior nutation. These are the dysfunction we will discuss in the coming slides. Okay, what are these dysfunctions are. So next is examination. Before going for the treatment, we will examine the patient that whether it is SI joint dysfunction or other low back pain or other hip pathology. So these are the some tests which we can include in the SI joint examination. First is anterior gapping test. I think you all are much familiar of these tests. So anterior gapping test, the test is positive if a unilateral gluteal or posterior leg pain is produced, indicating sprain in the anterior sacroiliac ligament. When we press, the patient is supine. I am not explaining the full procedure. That by looking at the picture, you can easily understand what is the anterior gapping test. With cross hands, we force the anterior side of the pelvis, and if the sprain is there, which indicate, or pain is there, that is which indicate there is anterior sacroiliac ligament involvement. Before starting, we learn some basic anatomy in that anterior sacroligament ligament we discuss in that ligament section. So this is anterior gapping test. Then second is Faber test for hip, rule out the hip pathology. The test is positive when knee is remaining above the opposite straight leg. जब जो बेंड किया हुआ नहीं है वो ऊपर ही रहेगा, पेनफुल होगा तो नीचे काउच लेवल पे नहीं जाएगा, तो वो ये जॉइंट पॉजिटिव, जब टेस्ट पॉजिटिव होगा, राइट. दैट इज फेबर टेस्ट. Then second is prone limb test. The patient is in prone position and we identify the leg length by the markers like heel and medial malleolus of the both legs with shoe off or shoe on. If limb length is discrepancy is small in 1 centimeter, 2 centimeter is there, then maybe SI joint dysfunction is present. Then second is GILLET test, known as one leg stroke test. In this test, the patient is in standing position and we palpate the PSIS of one side, and lateral to the PSIS we put our another thumb and then ask the patient to flex the knee up to the 90 degree. So if the that side of the moving knee side of the PSI should go inferior, if it's stuck or not going inferior or moving superior, then the test is positive. That means that side of the joint is hypomobile. Then second is seated flexion test. We palpate the PSI, both side of PSIS. One PSIS is inferior than other one. That means that lower one is subluxated or is involved. If in sitting position we palpate both PSIS, then instruct the patient into forward flexion. Then the lower PSIs become upper PSI. That means that SI joint is involved and the test is positive. Then second is Ganslin test, which include hip pathology, L for nerve root lesion or SI joint lesion may be there. That means when we go to that position, knee to chest position, and other limb is in side flexion or in supine at the side of the couch, and when we stretch, the pain is there. That means the test is positive. Then second, next is Yeoman's test. Pain localized the SI joint indicate pathology of the anterior sacroiliac ligament. In that test, patient is in prone position, knee is flexed, and sacroiliac joint is stabilized, and with other hand, therapist is moving the knee in upper direction, that is extension. So if pain is there, then SI joint is involved. Next is prone knee bending test. Then it is also for the hypomobility of SI joint. In that, the ipsilateral ASIS rotates forward usually before the knee reaches to 90° of flexion. When you bending the knee from extension to flexion, before 90°, the ASIS rotate forward. This is the positive test known as prone knee bending test for SI joint involvement. Now come to the dysfunction. These are the tests by which we rule out whether it is hip joint is involved, SI joint is involved, or some other pathology is there. So, how many dysfunctions are there in SI joint? So, first is rotatory dysfunction. This is rotatory dysfunction of the innominate. Innominate, we can see the PSIS and ASIS. So, in rotatory dysfunction, first is anterior or forward rotated innominate. That innominate is moving in the anterior or forward direction. That means ilium is going in the superior or anterior direction, right? In osteopathy, it is known as SA ilium, superior anterior ilium, and normally we call as anterior or forward rotatory innominate. And second is posterior or backward rotated innominate. In other words, or in osteopathy, we called as posterior inferior ilium. That innominate is rotated in the posterior direction. ASI is going upward and PSI is going downward. These are the second rotatory dysfunction of the innominate. Then next is sacral base dysfunction. In sacral base dysfunction, the base of the sacrum is going anterior direction or posterior direction. The first is base anterior dysfunction. That is, the base of the sacrum is going to the anterior direction. Look at this video. I am again playing it. The sacrum is moving in the anterior direction and stuck in that anterior direction. Basically, all dysfunction are the bones or the joints are stuck in one specific direction, or we can say, in other words, it's minor subluxation of that joint or bone. So in base anterior direction, sacrum is stuck in the anterior direction, that is base anterior dysfunction. Look at this video again. Okay. Then next is base posterior dysfunction. The sacrum is stuck in the posterior direction, that is base posterior. This is posterior movement of the sacrum. Then sacrum is stuck in the posterior direction, that is base posterior dysfunction. Once again, this is base posterior. Right. Next is sacral torsions. The sacral torsion means sacral is rotated either right side or either left side. So what is this torsion? They occur as a fixation on either on the oblique axis, like this base sacrum anterior or posterior dysfunction, that I already told you that sacrum is stuck in the anterior or posterior direction. According to that, we define base anterior dysfunction when the sacrum is subluxated in the anterior direction or stuck in the anterior direction. Like this, like that, sacral torsion are the sacrum is fixed or stuck in that oblique axis movement, which are normally occur in the gait cycle. So this dysfunction, how this dysfunction occur? By the culprit in that oblique dysfunction is the piriformis muscle. If the piriformis is involved and not working properly, then these oblique dysfunctions are occur. So torsion might be thought as a half of the sacrum is flexing and other half of the sacrum is extending in one of the two oblique axes. As we discussed, there is one right oblique axis and second is left oblique axis. When we look the sacrum posterior direction, our right hand, from my side, we are seeing the patient back side. From my side, my right hand is the patient right oblique axis, and from my left hand side, patient left oblique axis. Okay, so torsion, the half of the sacrum is flexing and half of the sacrum is extended in one of the two oblique axes. So sacral torsions are: first is forward torsion to the left on the left oblique axis. It's also in short form we said LOL, left on left oblique axis. So sacrum is forward torsion of the left sacrum on the left oblique axis. Look at this video, then you understand. This is the left oblique axis. The blue line is the left oblique axis, posterior side of the sacrum. This sacrum is moving in forward direction to the left on left oblique axis. Right? This is forward torsion to the left on left oblique axis. Second one is the forward torsion to the right on right oblique. Previously on the left oblique axis, this is on the right oblique axis. Right torsion, forward torsion to the right on right oblique axis. Okay, look once again. Sacrum is moving in the forward direction on the right side on the right oblique axis. Then next dysfunction is sacral backward dysfunction. The backward torsion to the right on left oblique axis. In previous one, on left oblique axis, the sacrum is moving to the right, and in this, the sacrum is moving on the right on the left oblique axis. Backward torsion. In previous dysfunction, the sacrum is moving in the forward direction. Look at once. This is backward movement, and previous one is forward movement on left oblique axis. Then backward torsion, next dysfunction is backward torsion to the left on right oblique axis. This is right oblique axis and backward torsion to the left. Look once again. Yes, this is backward torsion. Then unilateral sacral flexion or unilateral sacral torsion is there, in which sacral flexion lesion might be thought as a failure of one side of sacrum is extend and from counter nutate from the fixed position, that is right and left flexion. Okay, like this. Look once again. Okay, fine. Then come to the pubic shear lesions. The pubic shear lesions are the lesions in which pubic bone is moving either in the superior direction or either in the inferior direction. If it is moving in the superior direction, it is known as superior pubic shear. that you can see in the picture, lower one picture, that superior pubic shear, one pubic bone is moving in the superior direction, that is superior pubic shear, and in other picture the one pubic bone is the moving in the inferior direction, that is inferior pubic shear. Okay, the pubic shears are sliding of one joint surface in relation to the other in either one direction, either superior direction or inferior direction, right? Then come next dysfunction is innominate shear, that is superior innominate shear or inferior innominate shear. That is superior innominate shear is also known as upslip, and inferior innominate shear is downslip. In the assessment part, when we check the ASIS of the patient, they should be in one line. The right ASIS and left ASIS should be in the one line. If they are disbalancing, or one is superior or one is inferior, that means that one side of the innominate is going superiorly, that is upslip, that is superior innominate shear, or we can say the downslip, that inferior innominate shear, the one side of the innominate is going in inferior direction. That is, we can assess it very easily. Then come to the next point, the treatment of the sacroiliac dysfunction. So what is the treatment? We can treat the sacroiliac joint in so many ways. When you diagnose and you assess by special tests that there is definitely SI joint dysfunction, which torsion is there, whether sacrum is stuck in anterior direction or posterior direction. So what should be the treatment? So first priority for the patient is to reduce the pain. For pain relief, we are using our pain relieving modality, as we all are physiotherapists. So you can use the pain relieving modalities like TENS, ultrasound, whatever you want to use, you can use. There is no issue in that. So first major problem is pain relief. So for first reduce the pain of the patient, then go to the next thing. So the next treatment we can use kinesiotaping. It is now very popular. So kinesiotaping, those who are expert or those who are learned, they know how to tape the patient. So for local low back region, there is no problem, like in that figure 1, this 2 eye strips vertically and 1 horizontally strip is there for the SI joint dysfunction, or which side of the joint, either right side or left side is involved. When you diagnose, then make the star at the right side or left side, which side is involved. This is the treatment of kinesiotaping for the SI joint dysfunction. Then next is mobilization. Mobilization is we can use Maitland mobilization. First identified which structure is involved, first identified whether lumbarization or sacralization is not present, then you use mobilization. Simple Maitland rhythmic mobilization is very useful in that treatment. Then now advanced treatment is dry needling also is there. For treat the SI joint, we can use the dry needling. Then for rest, to give the rest to the patient, or for relaxation of the muscles, we can use the special belt is coming, which is known as sacroiliac belt, which can helpful in the initial phase. In my view and in my opinion, this belt or any lumbar belt or any sacral belt or any type of brace is only used for the acute phase. For initial phase, that is 2 to 3 days when the pain is severe. After that, these belts should be discarded. I am giving the reason because of that, because if we continue these belts, then they will restrict the mobility, restrict the healing, and they weaken the muscle. By the using of belt, the muscles are going weakened and weaker day by day, and that patient never recovered. So please discard these type of braces or supports after acute stage. That is my experience. Otherwise, you can make your own treatment plan. There is no issue. Then next is manipulation. So there are so many type of manipulation available which give instant results, but the therapist should be expert in that manipulation. So if we discuss these torsions and base anterior, base posterior subluxation or stuck or dysfunction, we can treat or we can correct this dysfunction in single manipulation if you are expert. So if you don't know how to do manipulation, please don't do that. Also, we have multiple skills, so many treatments are available. So if the manipulation is going wrong, then the pain will increase. So please don't do if you don't know how to manipulate. So lumbar manipulation is there, sacrum manipulation there, innominate manipulation is there. We can treat easily if you can know how to manipulate. Then next is MFR, myofascial release, very good treatment for the pain, any type of pain. We can release the fascia. The fascia is very important nowadays. No, previously it is also important, but now people are knowing that what is fascia. Fascia is present from primitive time, and we are knowing that what is fascia nowadays, but it is very popular from 1970s, 50s. People are working on that. So myofascial release is very good treatment. Now come to the cryotherapy. It is also very good treatment in the initial phase, only recommended for 15 to 20 minutes. And next is in last figure you can see the injection. What is this injection? You people may think that it is a steroid. It's not a steroid injection. It is known as a prolotherapy. Prolotherapy is a new advanced therapy. Prolotherapy means we are inserting the glucose in the joint, which we can start the inflammation again. In chronic cases which are not responding, the prolotherapy is very useful treatment. We induce the glucose by the injection, and we facilitate the inflammation again from the acute stage. So the patient respond well with the prolotherapy. Then come to the exercise. Our best part, with any treatment you can use physiotherapy, electrotherapy, braces, kinesiotrapping, dry needling. All treatments are not completed without exercise treatment, which is our main domain. So the exercise are very important. These some exercise I included which are very important and useful in the SI joint dysfunction. So first is bird dog exercises, second is knee to chest, second is cobra pose, then knee rotation, triangular pose, bridging, child pose, heel drag, standing crunch, quadruped arm leg raise, pelvic tilt and side plank. These are the common exercises which we can use in the SI joint dysfunction. And next treatment is surgical treatment, in which when the joint is not respond by any type of treatment, the last option is SI joint fusion. So we can fuse by the surgical procedure by triangular titanium implants. In that the joint is fused by surgical intervention. Then sleeping position in the SI joint. This position is the best position for the SI joint dysfunction or SI joint pain. Side lying and upper joint, yani involved joint is at upper side, lower joint, lower leg is flexed, upper leg slightly flexed, side lying position, the best sleeping position for SI joint dysfunction. So these are some activities which can avoid in SI joint involvement or dysfunction. So these exercises or these activities are biking, weightlifting, football, or any sports in which that vigorous movements are there. So stop that. Golf, crunches or sit up. These are the activities which should not be advised in SI joint involved. So low back pain missing piece, diagnosing the sacroiliac joint, that the literature says that 80% or 90% low back pain, the cause of that pain is SI joint involvement. So you can rule out, diagnose, assess and find out it might be the SI joint involvement. That is the key, home message from my side. Thank you very much. Any question from your side? Most welcome.
Good evening, Dr. Deepak, and thank you for this wonderful presentation and a very important piece of knowledge, I would say, when you have to diagnose differentially a patient of back pain, and that is really the biggest headache. And if you say 80% of the patients with back pain may have a component of sacroiliac dysfunction, I think it is very important to understand it and to rule out if there is a problem in the sacroiliac joint. Dr. Deepak, there are certain theories that SI joint cannot be mobilized because the movement is so less, and the primary purpose of the joint is to transfer weight and not to move.
Right, sir. You are right. The literature says the same. But when we mobilize the joint, there is that in literature is also told that there are slight movement is there. The small amount of movement is present in the joint. Right. If we mobilize, the joint is mobilized. Might be it is not visible. But right. if we go through that MRI studies or live MRI with mobilization, there is slight movement is possible. And if when we mobilize the joint, it's not like that, okay, sir, pain is coming from the joint also, or joint is mobilized. The surrounding structures which may be fascia, or it may be ligaments or muscles, they are also the pain producing structures. But by the mobilizing of the joint, they are also mobilized, and the pathway of the pain is changed. The next theory is that neurophysiological theory, sir. So might be that is important. So the movement is less, but it is not completely, that movement is not there. The movement is available, sir. Slight movement is there.
So, Dr. Deepak, what are the most common dysfunctions that you observe in the SI joint? Out of torsion, nutations, unilateral or bilateral, what are the most common that you observe, and what can be the most common cause clinically that a therapist should first rule out?
Sir, in my experience, I found every patient have sacral dysfunction. Either the sacrum is stuck in the anterior direction or posterior direction. And next is innominate dysfunction. Everybody, including me, that innominate is and sacrum is definitely stuck in either anterior direction or posterior direction. So the reason behind that is that we are we have all have sedentary lifestyle, and the joint is not moving so much. It's a very little movement is there. when we suddenly jump, or we can running, or we can climb up stairs, or we are coming downstairs, the joint is subluxated slightly, and this dysfunction occur. And sir, I told that this subluxation is not visible in the X-ray. These dysfunctions, these subluxation are not visible in the X-ray. If you go,
Right.
if you go into the orthopedician, they say that there is no problem in the joint. But
Right.
but when you assess according to that theories, that assessment, what I told, that innominate anterior innominate dysfunction, posterior innominate dysfunction, sacral anterior dysfunction, base posterior dysfunction. When you palpate it and when you assess, you will find that yes, definitely the sacrum is stuck in the anterior direction or posterior direction, or innominate is stuck in the anterior direction or posterior direction. And when you mobilize it or manipulate it, then it will definitely, the patient pain is relieved, which prove that definitely the joint is stuck in one direction.
Right. So, Dr. Deepak, like on examination, you find something. And this is very important because you say that X-rays cannot detect
Yes.
sometimes these dysfunctions.
Yes,
And how do you confirm if your palpation is right?
sir, when you
I
palpate,
think is it by symptoms of the patient that they are relieved?
patient symptom, and sir, there are 5 fundamental points of palpation, that when you palpate the patient, when the joint is involved, that sir, the ROM is slightly decreased, definitely, and the strength of the muscle is decreased, the temperature of that area is increased, and texture of the skin is different
Okay.
as compared to other part. So these are the 5 fundamental that important point in the assessment of palpation.
Right. And just one last question, Dr. Deepak, that you know that you have mentioned sometime in your presentation that SI joint dysfunction could be because of some muscular or facial reasons.
Yes,
So
sir.
if as a therapist, I am not trained in manual therapy, uh, can I target the structures like the piriformis or the biceps femoris or the fascia, and the SI joint dysfunction automatically corrects?
Right. Very important question, sir. No one, not everyone is expert in manual therapy, but we all are expert in our exercise therapy. Exercise
Yes.
by the exercise therapy, and that myofascial release, MFR. MFR, they are the new term came MFR, but we are doing MFR from last 70 years. It's nothing, it's that a release of the muscle. If we don't know anything, we know that how to release the muscle, that when we release the that fascia, that piriformis muscle, that automatically, sir, fascia is released.
Right.
When we that interpreted and when we assess the patient, we know that by simple muscle length test, that this muscle is in short position and this muscle is in lengthened position, or this muscle is in normal length. By the
Right.
muscle length test, we can easily diagnose. So the muscles which I mentioned, that these are the main muscle which reinforce the SI joint. If we assess only that muscle, then we know that this muscle is short and this muscle is lengthened and this muscle is weak.
So
By
I
the
think a very important point that you have highlighted is that sometimes we consider, because we are treating a joint, so manual therapy is the only treatment. But in treatment methods, you have mentioned the very important role of exercises, of taping, of MFR, of MET, facial release. So I think even though the problem is in one structure, but the dysfunction is actually transferred to all throughout the region and structures around it. So
yes,
it
sir.
is very important not to treat only the joint, but the whole region and the
Right.
patient himself.
Sir, I would like to mention one thing also, that
Yes, sir.
manual therapists are saying that we are treating this pain in one single treatment. This is not true. that
Right.
the pain is reduced, but it come
Yes.
again next day,
Right.
because that joint is stuck, and if we release the joint, then joint come again into that same position, because we are not treating the surrounding structures. And if we are not treating the surrounding structures by our exercise therapy or with the release or our electrotherapy, then this dysfunction never corrects, sir. So we overall take a holistic approach to heal the whole body. We cannot take a single joint. If joint is the problem is in SI joint, we have to check knee joint also, hip joint also, lumbar joint also, because one joint problem will definitely, it's a kinetic chain, it will affect on some other joint also, definitely.
Right. Yes.
So,
Thank you.
so it is not important to focus on that particular joint, sir. It is
Right. So really we are ending with a really very important point that we should look at the patient holistically.
Yes,
and thank you, Dr. Deepak, for sharing this wonderful piece of information today on sacroiliac dysfunction and its management. Thank you.
Thank you, sir. It's my pleasure.